Hello, my name is Adam Singer from Atlanta, Georgia, and today I'll be discussing ultrasound evaluation of soft tissue masses. Just before I begin, a brief disclaimer: this video and all the videos on my channel are for educational purposes only. They are not to be used to make medical decisions. If you have a medical issue or question, please consult with your medical provider and make the decision for your healthcare based on interactions between you and your medical provider. That said, I'll begin. So this is going to be the first of a series of videos on ultrasound assessment of soft tissue masses. The first one will be just background information and a brief review of several papers from the literature, and then the next several videos will be example cases. So to begin, soft tissue tumors are common. They often result in clinical presentation to a medical provider for assessment of the lump or bump, and it sometimes results in the need for diagnostic imaging. It's been reported that there's an incidence of 3 of these per 1,000 people each year, and the overwhelming majority of these are benign. It's been reported that 99% of them are benign. Lipomas are the most common of the superficial soft tissue tumors, and most lipomas are subcutaneous in location. Now, important to differentiate superficial masses from deep masses. So when we're talking about the trunk and the extremities, masses that are between the skin and the fascia on top of muscle compartments are considered superficial, and the overwhelming majority of those are benign, and they are often lipomas. When you talk about going deep to the fascia, so into muscular compartments, the rate of potential problems increases, and so these are sometimes treated differently. So important distinction, although some of these papers that we review will have a mix of superficial and deep masses, and I'll try to point those out as we go through. There are non-neoplastic causes for lumps and bumps, and so some of the more common ones that we encounter include synovial or ganglion cysts, usually adjacent to tendon sheaths or joints and arising from communication with one of those structures. Foreign bodies in the setting of penetrating trauma, often glass or wood. Hematoma if the patient is on anticoagulation, for example. Subcutaneous cysts such as epidermal inclusion cysts, fat necrosis in the setting of trauma, vascular malformations, abscesses in the setting of infection, rheumatoid nodules in patients with rheumatoid arthritis, neuromas following injury to a nerve, and seromas are sometimes seen as well. So to dive right into these papers, the first one that we'll talk about is from Radiology in 2004. This was a retrospective study, and you can see relatively small sample size, 39 masses, but these were 39 patients with pathologic correlations, so tissue was removed and it was compared to the ultrasound diagnoses. There were 3 reviewers. Readers 1 and 2 were radiologists who looked at the ultrasound images retrospectively, characterized them, and then tried to assign a differential diagnosis. And then reviewer 3 looked at the clinical report and the images and tried to assign a level of confidence based on the report and the findings. And so you'll see that there were 25 lipomas in the series, 14 non-lipomas, and the conclusion is probably the most important thing here. Unlike many of the other papers out there, this paper described a low accuracy in the diagnosis of soft tissue lipomas. A little bit more into the actual data. So when the reviewers looked at the masses and tried to determine the echogenicity, there was discrepancy. And what do I mean by echogenicity? So they used the muscle as an internal control, and they said, is this mass hyperechoic? Is it brighter than the muscle? Is it isoechoic? Is it the same as the muscle? Or is it hypoechoic? Is it less echogenic, darker than the muscle? Reviewer 1 said that 20% were hyperechoic, that is, 60% were isoechoic, and 20% were hypoechoic. Reviewer 2 said that 52% were hyperechoic, 28% were isoechoic, and again, 20% were hypoechoic. So there was a significant discrepancy between reviewers 1 and 2 in terms of hyperechoic and isoechoic. The hypoechoic, they seem to not have as much of an issue and agreed more there. In this series, 76% were reported, at least by one of the reviewers, to be superficial in location. And then getting down to, I think, the more important parts here. So the sensitivities for reviewers 1, 2, and 3 you can see ranging from the 40s to 50s, so somewhat low, and the accuracies the 40s and 60s here. So just keep these numbers in mind as we move forward toward other papers. This second paper is from the American Journal of Radiology, or AJR, and it was published in 2014. And this is a larger series of soft tissue tumors, and these were all superficial to the fascia. They had 714 masses. Of these, 247 had pathologic correlation. And compared to the accuracies that we were seeing before, in this paper they reported an accuracy when you take all of the potential diagnoses included, so the differential diagnosis for the masses, 79% were correct, 21% were incorrect. And then when you look only at the top diagnosis in that list that they gave, 77% accuracy. In this paper, 96% of the masses were benign. And then they went and looked at the sensitivity and specificity for some of the more common masses that they encountered. And so for the first one, the lipoma, they reported approximately 95% sensitivity and 94% sensitivity. For vascular malformations, 73% and 98% sensitivity and specificity. For epidermal inclusion cysts, 80% and 95% sensitivity and specificity, and for peripheral nerve sheath tumors, 69% sensitivity and 95% specificity. There were a small number of malignant tumors in this series. They reported a 94% sensitivity and a near 100% specificity. For the malignant superficial soft tissue tumors, it was 99.7. It is worthwhile to note that only 8 of the masses within this series were malignant, so kind of difficult to really get a good understanding for the true accuracy with such a low number of malignant tumors within the sample here. But in contrast to what we saw from the radiology article, if you look at the conclusion here, the author said that the diagnostic accuracy of ultrasound in the assessment of superficial musculoskeletal soft tissue tumors is high. And they thought that it was also accurate in differentiating benign and malignant superficial soft tissue tumors. This next paper is from the Radiology Clinics of North America from 2014, and this is more of a review paper, so not really a scientific paper, but a great reference if you want to see the varying appearances of different types of soft tissue tumors, so a nice reference here. This next paper is from the Journal of Ultrasound and Medicine from 2013, another retrospective study. Again, with a relatively small sample size compared to the AJR paper, but again with pathologic correlation. And in this series, among the lipomas, they found that 26% were hyperechoic, 59% were isoechoic, and 15% were hypoechoic. So seeing roughly similar ratios with, again, 15 to 20% in general being hypoechoic and the rest either being iso or hyperechoic. They did have Doppler imaging available for some of these. They said 74% of them had Doppler images available for review, and all of the masses that had this had either no flow or very minimal flow. So avid vascularity would not be consistent in this series with a lipoma. When you look at the diagnostic performance for making an accurate diagnosis of lipoma with ultrasound, you see the sensitivity, specificity, and accuracy reported, and you can see much higher than what we saw from the radiology article here. And there were all the readers here as well. A little bit of a difference here, and these again being superficial soft tissue masses. And finally, the article from 2000 from the Journal of Australasian Radiology, and this one looked at some of the potential pitfalls in using ultrasound to assess. And They reported a rate of 23% of incorrect initial diagnosis by ultrasound in this review, again with a small series of patients. And they did note that it made a difference and resulted in a delay of diagnosis in some cases. And they suggested exercising caution when making the diagnosis of hematoma. As we mentioned, these can be mistaken for benign hematomas when they're actually masses that have hemorrhage in them. So if there's not a good reason for the patient to have a hematoma, really would be worthwhile to at least image them with contrast to make sure there's not a solid mass there, and follow it up if you're not going to do tissue sampling, potentially. And if you do think it fits for a hematoma, worthwhile to at least follow it to resolution. Just make sure that there's not something underlying there. That's just a brief review of the topic. There are many more papers out there that talk about this issue, and I would encourage you to review some of these papers and some of the papers that they reference as well if you need more information on the topic. The next several videos will be example cases just to show with correlation. If you like this video or other videos on the channel, please subscribe, and if you really liked it, put some likes up there, and would appreciate passing this around on social media if you are a fan of these videos. Thank you very much. Have a good day.